how doctors are. Anyway, I think, and we look at the results depending on, if you're a surgeon, if you're a physiotherapist, or if you are, somebody else. So everybody looks at their own perspective. There's a question from Dr. Harshad Parekh, and he's asking, what's your recommendation for fusion versus non-fusion if there's no instability on radiology but listhesis?
Yeah. So exactly. So what is the actual practice? In my practice, if someone is elderly and there's only a grade 1 slip without dynamic instability, I will do a decompression alone. If there is instability of 4 millimeters or more, if there's a high disc, and if there's again that facet orientation that worries me, I will have to think twice. But if to keep things simple, if there's no dynamic instability, if it's grade 1, and especially in the elderly, there is plenty of evidence to let us do a decompression alone.
Sandeep, you want to take this question, please?
Yeah. So in my practice, we have gradually moved away from fusing almost, like, I'll not say everybody, but our fusion rate was almost 80% in degenerative spine. And now gradually we have moved away from it, and more often we are doing just decompression alone. So I was just looking at the data of last 5 years. So we had done 1600 decompression alone for canal stenosis and grade 1 listhesis, as compared to less than, I think, less than 300 fusions. So previously it was just the reverse. It's 8-9 years ago. So gradually we are moving away from fusions to decompression alone, and we have had pretty good results, and our reoperation rate is really low. But I must say that long-term satisfaction rates and pain rates were better in those patients who had decompression infusion, as compared to some patients of decompression alone who continue to complain of pain, but their MRI doesn't suggest any need for reoperation. So the reoperation rate is low, but still some patients are not satisfied. So I'm still not 100% sure what to do in which patient. So we choose each patient independently.
I would agree. It's all about personalized care, and the treating physician who has the patient in front of them should be the best person to judge the pros and cons of either option. I see there a question about the role
Dynamic
of,
fusion.
yeah, dynamic fusion systems. Is there any convincing indication? Well, I do have some experience with the dynamic stabilization using the Cosmic system by Ulrich Medical, and taking a step back, it's fair to say that there are different types of dynamic fusion systems. Some of them are pedicle screw based, like the one I'm referring to, and others are the so-called interspinal spaces, which in my opinion, I think are now outdated. There's plenty of evidence that those do not stand the test of time. I think the only long-term trial data that I'm aware of for dynamic fusion systems is that in the end they slowly fuse. The proposal was that they wouldn't fully fuse, that they would hold the segment together while maintaining some motion, but in the end they also fuse. But they haven't really become very popular, and most people I know have stopped using them. So that's all I can comment on that.
Mehmet, you have any comment on that, on dynamic fusion?
No, really. We need still some studies, high-level studies, to confirm that they have benefits of fusion.
Okay.
I would say just one thing in favor of decompression alone is that a lot of patients, particularly I'm talking about older populations, patients in their late 80s and early 90s, who are not really a very fit candidate for big surgeries. They are now coming forward to get operated. Otherwise, they would be scared of doing bigger surgeries. So we are operating a lot of patients in their 80s now.
Obviously, they're already fused, so majority of the time you don't need to worry about fusion there. So at that age, they are already fixed fused.
I agree with Salman and Sandeep that with age we get stiffness and they may not be classically fused, but they are as good as, and the compression alone is usually more than enough, unless there is overt instability. And going back to the word instability, this is the confusing term, right? I mean, what is instability means is explained in many different ways to very different people. So I think in the elderly, there's plenty of evidence now, even if we accept or not the RCTs, there's plenty of evidence that the compression alone for grade 1 is fine.
Okay, so at least we have consensus on that. We all agree on that. That's good. Any more comment, Sandeep?
I'm just checking if there are any questions.
Dr. Parekh is also asking a question about facetal screws, as suggested by Atul Goel.
I don't have experience of facetal screws, to be honest. I haven't used them. If I'm worried about true instability, I will use pedicle screws. I don't have experience of facet screws, to be honest. Do you guys, maybe you can shed light on that if you have experience of that.
Mohammed?
I think the faceted screws are weaker in construct, and they should not be primarily used in especially in lumbar spine.
Okay. Andres, thank you. It was really nice of you to be here, and
Thank you so much. Pleasure.
okay.
No, it's Wilco.
Thank you.
Thank you.
So we proceed to my presentation, Saman, or?
Yeah, I think Sandeep has just given you a hint that you have to start,
Yeah,
but
so I
it
can't
has
see
to be better than a hint.
Okay. So I was not posing any questions. Do you see my presentation now?
No.
Not yet.
Oh. Let's do it again. Share. And now?
Yeah,
Okay.
we can.
Now it is okay. Good.
It's okay. Do you see it clearly?
Yes.
Okay. So, well, I didn't pose questions to Andreas because I also have some remarks, and probably some of you might know that I like evidence-based surgery, but I think also society needs that. And well, I think that a lot of what we use in the degenerative lumbar spine is how our emotions are going. So for those who like to read some books outside the real medical field, this is a very good book because it is showing what we think in our brain, but also how our heart leads us sometimes to decision making in spine surgery, which might be added value to our patients, but sometimes also not so much added value. And emotions do play a role, especially if you are trained in a certain way and you cannot adopt another way. Yeah, I have quite a few conflicts of interest, which some of you know. It's important to know that the conflicts of interest outside of industry is also for the governmental grants. And if you think about governmental grants, sometimes the governments want other things than surgery. So that's a conflict of interest from my side. So Andreas also already showed you the both publications, both RCTs published in the New England Journal of Medicine. One by Professor Kokawola and the other one by Peter First from Sweden. One North American, one European. And I wrote some criticism on that because there's not real evidence to use pedicle screws in the elderly with lumbar spondylolisthesis. It's not talking about ischemic spondylolisthesis. And I received quite a lot of aggressive comments by email, which I won't share. And maybe my title talk about the superfluous surgical implant is not very nice. But the reactions were quite emotional, and I think most of them were economical. And that's important to realize. So what are the publications which the reimbursement governmental institutions use, and also the insurance companies? Well, if you look at this Lancet paper, which was published already quite a year ago and a few years ago, and if you look at the costs and also the impact of lumbar problems, low back pain, and degenerative spine diseases, we are quite high if you look at the leading cause. It was in 1990, it was number 1. In 2013, it was still number 1. And the same is true for neck pain, which we won't treat here. So it's important to realize that the outside world, not being the surgeons, are looking at us with a little bit of suspicion. And we have to be aware of that. So are we doing the right thing using our implants? And these kind of publications won't help. So if you look at this paper, which was published already quite a while ago by an analyst in 2007, you see that a lot of our publications are not that evidence-based, and more than 50% what we do, and that's in general surgery, but also medication, is not evidence-based. And if you look at what is beneficial, it's a lower group. So this is beneficial. So this is what we could do if you use instrumentation, but this is unlikely to be beneficial. And for spine surgery, lumbar fusion for low back pain in multiple level disc disease is in this range. So, and nowadays still reimbursement is paid for, but people will look at that. So that makes us to discuss with each other, are these toys for boys or not? I don't think so. We do need our implants. So I am not holier than the Pope. I won't say that I don't use implants. I use a lot of implants, but we have to prove that we need those implants. So if you look where we need it for trauma, oncological spine surgery, deformities with neurogenic compression, and also if earlier surgery has been done and a patient is destabilized. And Andreas was already talking and thinking, what is instability? And that's a difficult question in a lot of our patients. So the only thing which we ask from our societies, we need to prove why, how, when in the timing of conservative treatment in degenerative spine disease, it's added value to our patients. So if we can show it and prove it, which is already being done for quite a few implants or surgeries, then we are there. So going to the C-spine, we will never prove that this kind of reconstruction is adding value. But we all know as neurosurgeons and also orthopedic surgeons that we can never prove this. But if you go to the other side, thoracolumbar degenerative spondylolisthesis, but also degenerative scoliotic deformities, is this the right way to proceed? An elderly lady, difficult walking, is that by neurogenic claudication or weakness of the hips and upper legs? With after surgery is straight back, but on the cost of what? Well, we all know, and I showed it earlier in congresses, that this paper is read by a lot of people outside the surgical world. It's by Rick Dio, a very good epidemiologist, doing a lot of lumbar spine disease epidemiology research. And they showed that the risk of complications is 2 to 3 times higher with an odds ratio than a simple decompression in the elderly patients. So there's a rise in the United States in the amount of fusions for lumbar spinal stenosis for the same diagnosis by the insurance company declarations, that there's a rise in the use of instrumentations, and not only simple fusions, but also complex fusions, which I just showed. And with this rise, there's a rise in complication rate. Not complication rate only of nerve root damage, but also about cardiopulmonary or stroke complications and mortality. So we have to be aware. So do we really need to reconstruct? I think this needs reconstruction. That's my personal way. But how about a lady of 80 years? So if you look at the X-ray, it looks terrible. So I would go for fixation. But then 80 years, and the other thing is this the good way? Is this a construct in which we are happy to do that without pedicle screws in the midspine? So it's not only does instrumentation add value, but also what is the surgical technique and what's the right way? Or should we accept that people bend forward, which is not only in Asia, but also certain parts of Europe, quite regular, and probably also in South America and Africa. So accept the change of posture. So if you look at those different kinds of surgeries and different kind of maps in the BMG paper about beneficial, for tumor surgery, it's likely to be beneficial. Depends on the prognosis. But for low back pain in degenerative scoliotic deformity, there's no evidence for that. A lot of complications, but also a lot of costs. And this one, well, it is not about the lumbar spine. This falls in the category which we don't have proof. Maybe we can show it in future, but probably we will never have evidence to do that. But we need to. So that's the reason why I'm very eager to do that, and also to ask people throughout the world to also conduct studies. So I'm now in this hospital. I'm in one of those rooms here. And this is the course venue of our university in Leiden. This course venue, and also here, is not only for the students, but also for spine surgeons who are visiting this lab on the cost of Medtronic or G&G or Nuvasive to have courses here. So within my own hospital, I try to prove there's evidence-based medicine, but the big companies are giving courses in this lab, for instance, for kyphoplasty. So then the thing is, do we always need RCTs? Well, I think we need RCTs when possible. But if you look at degenerative spine disease without instrumentation and all the RCTs which has been done, it is showing a lot of evidence. We are happy with it. We are proud that we did all those studies. But if you look at what we did show, is that even for sciatica, all those 5 RCTs, they say that discectomy might be an option. So they call it low certainty evidence. So that's the difficulty. So on one way, we think we are doing a good job the last 20 years, but on the other way, people outside our field are showing that it's low certainty evidence. So those conclusions are frustrating because I was one of the authors of one of the RCTs, but also one of the authors of this publication. And I also made mistakes, and we did make a mistake. For instance, there's a very old PSD from my country, the week back, in which we induce degenerative instability by big surgeries, large surgeries. And what we can do is this study by Claudius Tomei, in which he showed that in lumbar spinal stenosis, you can do a minimal decompression without facet joint destruction. So if you do the surgery which I was trained in The Hague, wide laminectomy including facetectomy, then you induce instrumentation. Whereas if you do this, you don't need instrumentation, like Andreas was saying. And I think that this is implemented now throughout the world in all continents to do minimal invasive decompression. This is the minimal interlaminar approach, but currently there are also endoscopic approaches. But although we are proceeding the right way, there's still something like the failed back surgery syndrome. And earlier I already said there's no other equivalent in any other medical procedure, and especially in degenerative spine disease of the lumbar spine, this is an issue. And Alf Nachemson from Sweden, the late Alf Nachemson, because he died already quite a few years ago, he warned us for that. So if you look at all the implants, and these are very old slides, that I'm doing all those implants, and I did the same in my own clinic, used all those implants, disc prosthesis, PDM, even a disc prosthesis without any evidence. We used it, even IDET, which was not an implant, but a non-evidence-based interpretation. And the fusion by an axial lift was also very popular for low back pain quite a few years ago, I think more than 10 years ago. This was something I liked. I liked this innovation. And I tried to have money to do an RCT, but the company, which was in Spain, didn't want to give the money because they said, well, I have to sell and I'm a small company and we don't need evidence, but probably the evidence will show that it won't have added value. High costs, no added value. So that was my reaction at that time to the Spanish company. If we don't do any RCT, then stop the induction. I don't think that this will still happen again. And for low back pain, I don't see any reason to use axial lift, pedicle screws, or a disc prosthesis. At that time, we looked in Western Europe to the use of implants throughout Europe in the Western part. And you see there are differences. I don't have Eastern Europe, I don't have the worldwide data, but these are the big companies selling. And you see that there are differences. The yellow is in the medium, so that's the regular use of spinal implants. But a few countries have lower, like France, there's a lower use of implants. But these are the big companies, and in France there are also a lot of small companies. So it might not be that regular. But for instance, in my own area, Germany, Netherlands, and Belgium, and Denmark, these is the same populations. So these are the same spines. But there are huge differences. The red area is a high rate of use of spinal instrumentation, which you can explain in Switzerland and Austria because of the skiing and the winter sport, like trauma. But we don't have mountains here. And I don't think either in Denmark. So we cannot explain that by a higher rate of trauma in this area. So what is the matter here? Is that overuse of spinal implants or not? When we were discussing this slide with the governments in Europe, in Brussels, they said, well, Wilco, you have to measure with the spine community in Europe and probably worldwide with QALYs to show that expensive implants are adding value by using QALY differentiation between treatments. So you all know that one QALY is 1 year in complete health, utility 1. Well, that doesn't mean anything to our patients if you measure QALYs. But does that say something to you and myself as a doctor? Can we deal with that? Well, it's difficult, but we should, because what is happening is that in Europe, and I don't know about other continents in the world, they are looking at the cost effectiveness plan, the insurance companies and the governments. So they will look at the cost difference between one treatment versus the other treatment and to look if it is dominant and less costly. So if you have instrumented spine surgery compared to another instrumented spine surgery, and you can show that there's more effect by your surgery and it's less costly, then you are dominant. And then the reimbursement system will use that. That's the way how it works in the UK and also currently in the Netherlands. But if it is more costly, and you have a difference in treatment effect, then you have to show that the more costs is worthwhile the money. If it is less effective and more costly, then we have to stop. So that's the difference which is happening. This is difficult, it's econometrics, but society and healthcare decision makers are using this currently more and more. And if not in your countries, I have to warn you, it will also come to your countries. So we have to know what's happening there. We have to understand what is happening there, but also we have to deal with that with studies. So I will show you one example, which what we did, and something I believed in. I believed in interspinous implants. And this is really true, I believed in it. So 10 to 15 years ago, I used this ones. And these are the Coflexes, but there are many. And the reason for that, it was in 2008 published in European Spine Journal by Hans-Joachim Wilco, which is very good biomechanical engineer. A lot of you know him. And he looked at the biomechanical structures and specimens with implants of all those systems, the old Wallace system, the Diem, the X-Stop. I used the X-Stop on those years, but I was more convinced by the Coflex. So the Coflex and the X-Stop were widely paid for throughout the world and implanted in a lot of patients. We did do an RCT, and I have to be honest, Coflex was very happy to fund this RCT because, like me, they believed in their product. And what did we see in the RCT? We compared the Coflex implant with decompression alone for spinal stenosis. And there was no difference between both groups. And there were a lot of re-interventions, so re-surgeries in the IPD group. If you look at Euroquals and Qualis, there's no way an IPD can be cost effective in spinal stenosis. So even if you are willing to pay 100,000 euros per Quali, you will never be cost effective. So the Coflex should not be used for spinal stenosis as an implant alone. Maybe together with the decompression, but not instead of decompression. So the golden Coflex, we call it at that time, I still have the golden Coflex here in my room. Did we really need an economic cost utility analysis to prove IPD for lumbar stenosis is not worth the money? Well, we need this because it was used quite a lot and I believed in it, but in the end it was not effective. So in the Netherlands this is stopped, but I know that in still quite a lot of countries this is used. But I would say don't use it if you have a straight spine and just do a degenerative laminectomy. Finally, is RCT the way to proceed every time? Well, not always. This study, the Fabice trial, caused me to have gray hairs. It was a lot of waste of money for this trial because it was causing emotions. People were not able to randomize. Elderly patients could not be randomized between surgeries and wait and see in spinal stenosis. So then the other way is not doing RCT, but what we do in trauma to use comparative effectiveness research by using CER. So you don't do an RCT here, but you use the real world difference, and we all treat our patients differently, and then go back and use this variation to look at differences. So going back to this case, difficult case, I wouldn't do this kind of surgery. I would do it differently. I would never use PLIF cages or X-lift cages without pedicle screws here. But if we want to prove that this adds value, then we can use comparative effectiveness research if we are not willing to randomize. I would operate a patient like this if he or she is 60, not if it's 80, but then what kind of surgery? So we have to go from evidence-based medicine to medical practice-based variation. Use that and ask people in your university to look at health services research because it is more difficult. We need the real-world data after a small study, preclinical, and go away along the time. It takes 10 to 20 years to do that. So the young spine surgeons within your group, let's do that. So do we have the answer? Prove what you add value, measure costs, and do a CEA or a CUA. Present this added value to the patients, to your peers, but also to the society. Show that you're proud that you did something like that. Be honest. Search for the evidence. And even if it is looking golden, look for the evidence. And if proven cost effective, realize reimbursements. So 100 years ago, Emery Cotman and Harvey Cushing were already saying we should compare our results. Emery Cotman wanted to have an end result hospital in 1917. He was fired for that in Boston because at that moment, money was more important than status. Thank you very much.
Thank you, Wilco. I think an awesome talk. Really enjoyed that. Sandeep, your take?
Yeah, I really loved the talk. It was pretty mesmerizing. Wilco, you really nailed it. And I really loved it. Now I really miss that you could not come to our conference in 2019 because of visa issues. I wish, yeah. So
thank you. Sorry for that.
yeah. No, just go ahead. If there are any questions here, I think
Andres?
good. So
do I have questions for Wilco? Yes, I always have questions for Wilco. Wilco, we talk a lot about moving away from randomized controlled trials to comparative effectiveness research, especially for surgery. But then we always see the pressure, I don't know if it's psychological or institutional or whatever, to again do RCTs. When and how can we show that CER might be superior to RCT for certain conditions?
I think that, well, we showed it in brain trauma now, but there's still